Hello everyone, welcome to PodBites, where we break down complex medical topics into bite-sized pieces perfect for your commute, coffee break, or whenever curiosity calls. I'm Noor Waseem, your host for today's episode, and I'm joined by Nada Alshaer to discuss acute kidney injury, chronic kidney disease, and everything in between.
Hello, everyone. This is Nada. It's great to be here. Let's jump into our discussion.
So Nada, let's start with the basics. What exactly is acute kidney injury?
All right. Acute kidney injury, or AKI, is a sudden and sustained decline in kidney function, characterized by azotemia or an increase in blood urea nitrogen, or BUN, and serum creatinine, along with oliguria or a reduction in urine output. This condition develops over hours to days and can progress quickly if not addressed.
Sounds like something that can get serious really quickly. So, what types of AKI are there?
Good question. AKI is classified into three main types: prerenal, intrinsic, and postrenal. Each has its own causes, diagnostic clues, and treatment approaches. Let's start with prerenal AKI.
So, what's prerenal AKI all about?
Prerenal AKI occurs when reduced blood flow to the kidneys leads to inadequate perfusion. Unlike other types, there is no structural damage, and it's often reversible if treated early.
And what kind of things can lead to prerenal AKI?
The most common causes are hypovolemia from dehydration, bleeding, or diuretics, heart failure causing reduced cardiac output, and sepsis, which leads to systemic vasodilation.
Got it. So, hypovolemia, heart failure, and sepsis. And what exactly is happening to the kidneys during prerenal AKI?
When blood flow to the kidneys drops, the glomerular filtration rate, or GFR, also decreases. The kidneys compensate by activating the renin-angiotensin-aldosterone system, otherwise known as RAS, which increases sodium and water reabsorption to maintain blood pressure and perfusion.
Okay, so I assume this means urine sodium would be low in these patients?
Yep, that brings me to my next discussion: diagnostic clues. How to easily identify prerenal AKI.
Oh, so what are some diagnostic clues in this case?
Key diagnostic clues include elevated BUN to creatinine ratio greater than 20 to 1, which reflects reduced perfusion. Low urine sodium lower than 20 millimole per liter, as kidneys try to retain sodium. Fractional excretion of sodium, or FeNA, is typically less than 1%, indicating intact tubular function. Concentrated urine with high osmolality greater than 500 milliosmol per kilogram, indicating intact ability to concentrate urine.
Okay, so we mostly look at BUN to creatinine ratio, urine sodium, fractional excretion of sodium, and urine osmolality. Nada, is there a way to calculate fractional excretion of sodium?
Yes, FeNA is calculated as urine sodium times plasma creatinine over plasma sodium times urine creatinine, altogether multiplied by 100.
Got it. And how do we treat prerenal AKI?
The focus is on restoring blood flow and perfusion. This can include IV fluids for dehydration, vasopressors for patients in septic shock, addressing underlying conditions like heart failure. If treated early, the prognosis is excellent, as the kidneys can fully recover. All right, if that's all clear, let's move on to our practice question.
Okay, listeners, here's a question for you. What lab finding is the hallmark of prerenal AKI?
The answer is an elevated BUN to creatinine ratio greater than 20 to 1.
Good job. Now, let's move on to intrinsic AKI. What's happening here, Nada?
Intrinsic AKI involves direct damage to the kidneys themselves, often affecting glomeruli, tubules, or interstitial tissue. The most common cause is acute tubular necrosis, or ATN. Another significant cause is acute interstitial nephritis, or AIN.
Interesting. Let's start with ATN. What should we know about it?
Acute tubular necrosis is caused by injury to the tubular cells. This can be either through ischemic injury, which is more commonly seen in proximal tubule and thick ascending limb, nephrotoxic injury, which is more commonly seen in proximal tubule.
Right. And what can cause these ischemic and nephrotoxic injuries?
Ischemic injury happens due to prolonged hypoperfusion, while nephrotoxic is associated with exposures to nephrotoxins such as aminoglycosides, radiocontrast agents, or myoglobin from rhabdomyolysis.
Got it. And what's going on at a cellular level during ATN?
In ATN, the tubular cells lose their polarity, leading to disrupted ion transport. Dead epithelial cells flood off, causing luminal obstruction and increased intratubular pressure. This results in reduced GFR. You may also see backleakage of filtrate into the bloodstream due to damaged tubules and vasoconstriction that worsens ischemia.
Oh, that makes sense. What are the diagnostic features in ATN?
Key diagnostic features for ATN include muddy brown casts in the urine, high FeNA greater than 2%, a BUN to creatinine ratio less than 15:1.
And how does acute interstitial nephritis or AIN differ?
AIN is primarily an inflammatory process affecting the interstitium and tubules. It's often a hypersensitivity reaction to drugs like NSAIDs, penicillins, or proton pump inhibitors. Other causes include infections and autoimmune conditions like sarcoidosis or Sjogren's syndrome.
So, how does the inflammation in AIN affect kidney function?
In AIN, immune cell infiltration and interstitial edema disrupts the kidney's ability to filter and reabsorb. This can lead to acute kidney injury with elevated serum creatinine, hematuria, and sometimes eosinophilia.
Okay, that makes sense. But Nada, how can clinicians differentiate between ATN and AIN?
Well, they do have different diagnostic clues that can help them differentiate them. In AIN, we look out for things like a history of drug exposure, presence of eosinophils in urine, and interstitial infiltration seen on biopsy.
And how are these conditions treated?
For ATN, management involves supportive care, avoiding nephrotoxic agents, and dialysis in severe cases, and it shows a good prognosis if underlying cause is addressed. On the other hand, AIN, stopping the offending drug or treating the underlying cause is crucial. Corticosteroids may be used to reduce inflammation, and early intervention typically leads to full recovery.
Thanks, Nada. So, intrinsic AKI includes ATN, caused by tubular injury, and AIN, driven by inflammation. Both have unique diagnostic features and treatments.
Yep, exactly. Now here's a quick question. What urinary finding is specific to ATN? The answer is muddy brown casts.
And finally, what about postrenal AKI?
Postrenal AKI occurs due to obstruction in the urinary tract, which leads to increased pressure in the kidneys and reduced filtration.
Okay, what's blocking the system in these cases?
So the common causes include kidney stones or urethral obstructions, prostate enlargement in men, tumors compressing the urinary tract.
Alright, how does this affect the kidney function?
Obstruction increases pressure upstream, causing hydronephrosis and decreased GFR. Prolonged obstruction can lead to tubular atrophy and irreversible damage.
So, how is postrenal AKI diagnosed?
Key clues include renal ultrasound showing hydronephrosis, elevated creatinine and BUN, and symptoms like anuria or difficulty urinating.
Okay, how do we fix this?
Treatment focuses on relieving the obstruction, catheterization for bladder outlet obstruction, as well as surgical removal of stones or tumors. Early treatment leads to full recovery, but delays can cause permanent damage.
Okay, now, listeners, here's a question for you. What imaging finding is a characteristic of post-renal AKI?
And the answer is hydronephrosis.
All right, Nada. Now, let's shift gears to chronic kidney disease. What is CKD?
Chronic kidney disease, or CKD, is defined as a decline in kidney function lasting 3 months or longer, with a GFR less than or equal to 60, or evidence of kidney damage like proteinuria.
Okay, what are the major causes of CKD?
The major causes of CKD include diabetes, the leading cause of which is diabetic nephropathy, hypertension, chronic high blood pressure damages the kidney over time, chronic glomerulonephritis, inflammatory conditions of the glomeruli, polycystic kidney disease, and other inherited disorders, autoimmune conditions like lupus nephritis. Each of these factors contributes to long-term damage to the kidney structures.
So, Nada, what's happening in the kidneys as CKD progresses?
As CKD progresses, there is ongoing nephron loss. The remaining functional nephrons compensate through hyperfiltration, which increases their workload. This initially maintains filtration, but leads to glomerular damage over time. This process causes glomerulosclerosis, interstitial fibrosis, and ultimately reduces the kidney's ability to filter blood, regulate electrolytes, and maintain acid-base balance.
Oh, that's a lot going on. Nada, I've heard that CKD is divided into stages. Can you walk us through those?
Of course, the stages are based on GFR and are as follows. Stage 1. GFR is greater than or equal to 90, with evidence of kidney damage. Stage 2. GFR is between 60 to 89, with mild decline in function. Stage 3 has two parts, A and B. For 3A, GFR is between 45 to 59, with moderate decline in function. And for 3B, GFR is between 30 to 44. Stage 4, GFR is between 15 to 29, severe decline. And stage 5, GFR is less than 15, indicating kidney failure. This is also known as end-stage renal disease, or ESRD.
That's interesting. But Nada, how can we catch CKD early before it becomes severe?
So early detection is key. Diagnostic tests include measuring GFR to monitor kidney function, checking for proteinuria or albuminuria, which indicates damage, blood tests showing complications like anemia, hyperphosphatemia, and metabolic acidosis, imaging studies such as renal ultrasound to look for structural changes like shrunken kidneys.
Okay, tell me, how is CKD managed to prevent progression?
Well, management focuses on slowing progression and addressing complications. Key strategies include 1. Controlling underlying causes. Manage blood sugar in diabetics, targeting HbA1c lower than 7%. Lower blood pressure with ACE inhibitors or ARBs. 2. Dietary adjustments. Low protein diet to reduce uremic symptoms. Restrict sodium, potassium, and phosphate to prevent imbalances. 3. Managing complications. Treat anemia with erythropoietin-stimulating agents and iron supplements. Use phosphate binders and vitamin D analogs for bone and mineral disorders. 4. Advanced stages. Patients with stage 5 CKD often require dialysis or kidney transplantation. The earlier CKD is diagnosed and treated, the better the prognosis.
All right, now here's one for our listeners. At what GFR does CKD progress to kidney failure?
And the answer is GFR less than 15, which is stage 5 CKD, also called as end-stage renal disease or ESRD.
Finally, Nada, let's summarize everything we covered today.
Sure, here's a quick recap. Prerenal AKI, caused by reduced blood flow, diagnosed by an elevated BUN to creatinine ratio greater than 20 to 1, and treated by restoring perfusion with fluids. Intrinsic AKI, especially ATN, involves direct kidney damage from ischemia or toxins, characterized by muddy brown casts in the urine, and treated with supportive care and dialysis if needed. Postrenal AKI results from urinary obstruction, diagnosed with imaging showing hydronephrosis, and treated by relieving the blockage. CKD, a progressive decline in kidney function, staged by GFR and managed by controlling underlying conditions, dietary changes, and treating complications. Advanced cases require dialysis or transplantation. And that's it.
Thank you so much, Nada, for breaking this all down for us. And to our listeners, thank you for tuning into PodBites. Don't forget to follow us for more episodes where we simplify medical topics just for you. Take care and see you next time.